Hello, this is Stephen Holloway. We'll be discussing coronary artery disease for the next few minutes, and this is part of Nursing 202, Module B. Your reading assignments are IGGY, chapters 35 and 40. Suggest also you do the workbook on these chapters as well. You can also use your Pharmacological Aspects of Nursing Care, the 7th or 8th edition, which is by Broyles, Reese, Evans, chapters 17, 18, 19, 20, and 21. Have information on medications used in treating heart disease, lowering cholesterol. So those chapters will give you the information you need on medications for cardiovascular disease. Other sources that I used in my research on this include the Advanced Cardiovascular Life Support Providers Manual, Cardiovascular Care Made Incredibly Visual by second edition, National Heart, Lung, and Blood Institute, the National Institute of Health's website, and the Center for Disease Control and Prevention's website as well. Coronary artery disease is the most common type of heart disease, killing nearly 380,000 people annually. When you look at that, that's basically about one death every 25 seconds from heart disease. When we look at those type issues. We see that basically every year about 720,000 Americans have a heart attack. 515,000 of those are a first-time heart attack, and 205,000 are people who have already had a heart attack but are having a second or third heart attack. Coronary artery disease alone costs the U.S. $108.9 billion each year. This total includes the cost of healthcare services, medications, and lost productivity. Heart disease is the leading cause of death for both men and women, and coronary artery disease is the leading cause of permanent disability in the U.S. Little extra facts on women and heart disease. Heart disease is the leading cause of death in women in the United States, killing almost 300,000 women in 2009. That's nearly 1 in 4 every female deaths. The same number of women and men die each year of heart disease in the United States. Despite some increasing awareness over the past decades, only 54% of women recognize that heart disease is their number one killer. If you talk to women, most would tell you that breast cancer or cancers are the number one killer of women. Heart disease is the leading cause of death for African American and white women in the United States. When you look at Hispanic women, heart disease and cancer roughly have the same number of deaths each year. For American Indian and Native Alaskans and Asian or Pacific Islander, heart disease is only second to cancer. About 5.8% of all Caucasian women, 7.6% of black women, and 5.6% of Mexican American women have coronary artery disease. As we look at this more, we'll look at the incidence and prevalences a little bit more. 64% of women and 50% of men who had an MI were unaware that they had coronary artery disease. These people had no idea that they had plaque building up in their vessels in the heart. Their first indication of having coronary artery disease was having an MI. Every 26 seconds, a person in the U.S. has a coronary event. And every minute, someone will die of a coronary event in the U.S. The average age for the first heart attack in men is 64.5 years of age. In women is 70.4 years of age. When we look at women, one of the things that we see with women, they are delayed in having their first MI, but once they have an MI, they have a greater chance of dying during that first year after having a heart attack. Women have the protective effect of natural estrogen, and that's why we see the onset of cardiovascular disease in women being delayed somewhere between 5 and 10 years. Many years ago, we thought we could provide that same protective effect by putting women on hormone replacement therapy. Evidence-based practice has now shown that is not true, that it really does not help prevent coronary artery disease or heart disease in women by putting them hormone replacement therapy. It really causes more risks than it causes benefits when we look at hormone replacement therapy. The CDC looks at deaths by ethnicity. You can see these statistics. You can see that the Caucasians have the highest instances of death by coronary artery disease, only followed by the African American population and then the Asian and Pacific Islander populations. When we look overall, it's not very good when we look at 25% of the deaths in the U.S. are caused by some type of heart disease problem. We talked about that many of the people who have heart attacks don't realize that they have coronary artery disease. Here's another statistic that you may not be aware of, that many people who have a coronary event die without ever reaching the hospital. So someone basically who has no idea they have coronary artery disease has a heart attack. From that MI, from that heart attack, they develop a lethal arrhythmia, either ventricular tachycardia or typically ventricular fibrillation, and die from it. 95% of sudden cardiac arrest victims die before reaching the hospital, most due to ventricular fibrillation. And that number is actually higher when you look at the African American population as we look at the ethnicity type issues with these patients. Now, of course, we know that the southern part of the United States is kind of the leading area when we look at heart disease. We know that by looking at statistics from the CDC. This one actually comes from 2007-2009 and looks at adults ages 35 and above and looking at the different counties. You can see Alabama here. Let me get it. Alabama. And kind of look at the different counties. Madison County would be right in this area. I'm sorry. And you look, basically as we look, we have really 450 to 750 deaths per year per 100,000 of people. And that's pretty significant. But as you look through, we're not the only area. As most of the time we say, thank God for Mississippi. They tend to be a little bit worse than we are. That's not a thing to brag about when we look at these type issues. But we see this and we look at, not only do we look at heart disease, but if you look at obesity, you look at diabetes, you'll see these same areas run very close together in the risk factors as we look at those type issues. Now, what is coronary artery disease? Coronary artery disease is a broad term that includes chronic stable angina and acute coronary syndromes. Coronary artery disease affects the arteries that provide blood and oxygen and nutrients to the myocardium. When the blood flow to the coronary arteries is partially or completely blocked, ischemia or infarction of the myocardium may result. So when we look at coronary artery disease, it's broken down into chronic stable angina or angina, whichever way you wish to pronounce it, and then into acute coronary syndromes. The acute coronary syndrome is defined either by ischemia, which is when occurs when insufficient oxygen is supplied to meet the requirements of the myocardium, or infarction, which is necrosis of cell death, that occurs when severe ischemia is prolonged and decreased perfusion causes irreversible damage to the tissue. As we look at the coronary arteries, I'm not going to spend a lot of time on this, but you do need to understand that basically as we look at the coronary arteries, that they supply different parts of the heart as we look at that. Your main arteries basically are going to be your left main artery. It divides into two sections, the LAD, or the left anterior descending, and the left circumflex artery. The LAD descends toward the anterior wall and the apex of the heart. It supplies blood to the portions of the left ventricle and the ventricular septum, chordae tendineae, papillary muscles, and to a lesser extent the right ventricle. The left circumflex descends toward the lateral wall of the left ventricle and the apex of the heart. It supplies blood to the left atrium, lateral and posterior portions of the left ventricle, and sometimes the interventricular septum. In approximately 50% of people, it supplies the SA node. In a very small percentage, it supplies the AV node. Now, the right coronary artery originates from the right sinus area, and it encircles the heart and descends toward the apex of the right ventricle. The RCA, or the right coronary artery, supplies the right atrium, right ventricle, and in 50% of the people, it supplies the SA node, and in most people, supplies the AV node. So if you look at thinking about things like such as that, if you think about someone who has blockage, say of the RCA, the right coronary artery, one of the big problems can be blockages or damage to that AV node, which can lead to complete heart blocks or second-degree heart blocks. So kind of important to understand where they do flow and where they go. Now, other terminology that we'll need to talk about will be arteriosclerosis, atherosclerosis, ischemia. We talked about infarction. And when we talk about infarction, we're going to talk about a STEMI and a non-STEMI. STEMI just means ST elevated MI. The non-STEMI, NT-STEMI, or non-STEMI as we will call it, is a non-elevated ST segment MI. So when we get over to talking about MIs, we'll talk about that a little bit more. So what is arteriosclerosis and what's atherosclerosis? Arteriosclerosis is a thickening of the walls of the arterioles with loss of elasticity and contractility. Arteriosclerosis typically develops with age and is made worse with hypertension, diabetes, cholesterol, and nicotine will tend to make it worse, so smoking. Now, atherosclerosis is an abnormal accumulation of lipid or fatty substances in fibrous tissue, creating blockages or narrowing of the vessels. Take a quick look at this video. Hopefully it will play, and it'll talk about atherosclerosis.
Unstable angina results from rupture of an atherosclerotic plaque with subsequent thrombosis and obstruction of flow through a coronary artery. Atherosclerosis begins with endothelial injury. Macrophages that are filled with lipoproteins are called foam cells. These migrate into the vessel wall and accumulate, forming fatty streaks. Smooth muscle cells migrate over the fatty streak, and fibrous tissue is synthesized. This forms a plaque, which can partially obstruct the lumen of the vessel. Unstable plaques are those with a thin fibrous cap and a rich lipid core. When these plaques rupture, platelets begin sticking to the exposed underlying tissue and form a clot that can completely occlude the vessel. If the clot dissolves within 10 to 20 minutes, tissue perfusion is restored before infarction can occur. This usually results in the acute coronary syndrome known as unstable angina and indicates a high risk for subsequent myocardial infarction.
So that's just a brief look at atherosclerosis. Now again, they talked about basically it develops with injury to the arterial endothelium. That can be caused by several different issues. It can be caused by damage from hypertension, from a nicotine, from diabetes, from vascular disease type processes, from hyperlipidemia, from obesity. All of those can cause damage to that area. This is just a visual look at the same process that we talked about with the damage being caused by hypertension, tobacco, hyperlipidemia, homocysteemia, hemodynamic factors, diabetes, infections, and immune reactions. So what we do is we get a damage here to the area, and because of that damage, we get those foam cells moving in. The foam cells begin to do the plaque. The fibroblasts, everything kind of moves over and covers the area. What can happen is we can get a rupture of this area, which will end up causing a thrombus and causing a total blockage of the area. Now, when we start talking about some of the diagnostic processes, one of the things we'll talk about is coronary artery CTs. And what the coronary artery CTs are doing is actually looking for these fatty streaks and these plaque buildups in the coronary arteries. So those can be seen on CT scan as we move forward in looking at some of the diagnostic processes. So ischemia we talked about. Ischemia is an insufficient oxygen supply to meet the requirements of the myocardium. Ischemia can be caused by that plaque buildup. It can be caused by one of the a thrombus being caused from the plaque buildup. Ischemia is basically where there's not enough oxygen getting to the muscle. And you can see that in patients who have those plaque buildups and maybe they go out and start exercising. If they're just walking around normally, there's not a problem. But as you increase the oxygen demand of the myocardium, there's enough blockage there that they can't get the oxygen supply that the heart needs. And these patients will begin having chest pain. Those are typically what we call angina attacks or those type of things. Infarction is necrosis or death of the cells that occurs when the severe ischemia is prolonged and decreased in perfusion. Once an infarction takes place, it's irreversible. So the tissue damage is there, it stays. Scar tissue will begin to form over that area. And the heart never fully recovers from that. You have the myocardium replaced by scar tissue. The whole goal in coronary artery disease is basically prevention. You wouldn't know that to look at our population in the United States, but that's really what we need to do, and we as nurses really need to work at moving and helping patients understand how to modify their health and modify and make things better to reduce the risks of coronary artery disease. When we look at the risk factors for coronary artery disease, we break those down into modifiable and non-modifiable risk factors. And we'll talk about most of these as we go along. Modifiable risk factors are elevated serum lipids, tobacco use, limited physical activity, which usually will lead to obesity, hypertension, and diabetes. Excessive alcohol use and stress are all considered modifiable risk factors. Your non-modifiable risk factors are things such as age, gender, family history, and ethnic background. Recently, the National Institutes of Health, National Heart and Lung and Blood Institute, I'm going to go 2 slides ahead here, convened the ATP4, which is the Adult Treatment Panel, looking at the management of hyperlipidemia. That was convened in 2008. They were to actually replace the ATP3, which had been published in 2001. It took them until November of 2013 to actually come up with the new ATP4 guidelines. In November 2013, the American College of Cardiology and the American Heart Association released a clinical practice guideline to guide the treatment of blood cholesterol and to reduce the cardiovascular risk in adults. I'm going to talk about a synopsis of those major recommendations as we go along. Unfortunately, the total ATP4 has not yet been published on the NIH and NHLBI website, so I can't give you a copy or send you to that website to look. This basically is from the American Heart Association and what the guidelines mean to the individual. As you can see, the new cardiovascular prevention guidelines basically were based on research evidence, where we looked at the medications and looked at the endpoint. The endpoint of the new guidelines is not a level of cholesterol. As in ATP3, we looked at lowering the cholesterol to a certain level. What this looked at is actually decreasing the risk of cardiovascular diseases, and that's our endpoint, is the reduction of cardiovascular diseases. So basically it all starts with an assessment of your risk factors that's performed by your healthcare provider. Then that person is discussed, the healthcare provider and the person get together and discuss. Then that person's got to make decisions. Everything is personalized for the treatment of that patient. We look at assessment of the risk factors for heart disease and stroke. All this is going to go in as we start talking about stroke next semester. It all falls in the same area. And we'll talk about different calculators to assess your risk and personal risk, and risk for strokes and for those. It talks about obesity, looks at cholesterol, and lifetime lifestyle type changes as you can look at those areas. So we talked about that. So the American College of Cardiology and the American Heart Association's clinical practice guideline based on ATP4 starts out with number 1, encourage adherence to a healthy lifestyle. Now, we have been pushing that with Healthy People 2000, Healthy People 2010, and Healthy People 2020 guidelines. We've been pushing that for years, trying to get the American population to buy into a healthy lifestyle. Unfortunately, it's very difficult to do, and we see those. But the biggest things that we're going to talk to our patients about, and this is where you as nurses may be more involved with this clinical practice guideline, is educating these patients on these healthy lifestyle modifications. The things we're going to talk to the patients about are diet, exercise, tobacco cessation. I put down there stop smoking, but we really are going to be not only just looking at smoking, but use of tobacco, chewing tobacco, snuff, those type of things. All of those are going to cause the same type problems when we're looking at cardiovascular type changes. Let me throw in here as well that the new trend in vaping, or basically the electronic cigarettes, does not help with this process. In vaping, you are still getting the nicotine in, which is the culprit in causing a lot of these cardiovascular risk factors that go along with smoking. Yes, the electronic cigarettes do help with the reducing the cancer, lung cancers, and the lung diseases, but does not reduce your risk of stroke and heart attack in using those. So, really, vaping. If you don't smoke and you don't use the electronic cigarettes, don't start. That's my word on that. And weight loss. When again we look at the United States, we're basically a large nation when we look at that. Now, this is basically a diet. This is a similar diet that was used with ATP3. Again, what we're looking at is recommended intakes when we really want to decrease the amount of saturated fats and basically up the use of monosaturated fats for our calories. Total fat by calorie should be 25 to 35%. Our carbohydrates should be 50 to 60% of our total calories. Fiber, we should be getting 20 to 30 grams per day. Protein, approximately 15% of our total calories. And cholesterol, less than 200 milligrams per day. Really got to balance our intake with our amount of energy that we're burning. Because if you don't burn the calories that you take in, the calories are then deposited as fat stores and leading to hypertension, diabetes, obesity, those type issues as you look at it. The second process in the clinical practice guideline is statin therapy is recommended for adults and groups demonstrated to benefit from the use of statins. In ATP3, there was a large number of drugs that could be used because we were looking at actually lowering the percentage of LDL to an endpoint. What the new studies have shown is that statin drugs have a significant benefit in reducing cardiovascular disease. So what the major drug that should be used as part of ATP4 are your statin drugs. And I have a list of those drugs for you a little bit later on. But the four major statin benefit groups are patients with clinical atherosclerosis, cardiovascular disease, so someone that we already know that has a cardiovascular disease in process, okay? Patients with an LDL, low-density lipoprotein, of 190 milligrams per deciliter or higher. Patients aged 40 to 75 who have diabetes but not clinical cardiovascular disease, and an LDL somewhere between 70 and 189. The last group of patients are patients without clinical atherosclerosis, cardiovascular disease, or diabetes who have an LDL of 70 to 189 with an estimated 10-year risk of a atherosclerotic cardiovascular disease of 7.5% or higher. Now, I will show you how to calculate that 10-year risk a little later. It's very simple. It's an app that can be downloaded to your cell phone, can be done on the internet, but we'll show you those type things. The third point in the clinical practice guideline is statins have an acceptable margin of safety when used in properly selected individuals and appropriately monitored. Just understand that basically when we start looking at these patients, we do need to monitor them. Now, before we would definitely monitor patients with the statins for changes in AST, ALT, and creatinine kinase in these patients. But that's no longer recommended unless the patient is showing clinical signs and symptoms of having liver problems, hepatotoxicity, or having severe myopathies, or maybe even possible rhabdomyolysis. So those are some of the things that we will really look at for these patients. That's where these patients have to come back and see their healthcare providers. That's where good education, talking to them about the side effects of these medications and how to take these medications. Again, that falls back to us as nurses to do the teaching on these patients, especially if they're in the hospital, started on a statin for the first time and being released home. That is going to be our responsibility to provide that education. Fourth step in the clinical practice guideline is engage in a clinician-patient discussion before initiating statin therapy, especially for primary prevention in patients with lower risks for ASCVD. Again, you may be involved as nurses as you do some of the education on these patients, but it's ultimately up to that provider to explain to that patient why these statin therapies are important, the risks that are involved with them versus the benefits of these medications. The use of newly developed pooled cohort equations for estimating 10 years ASCVD risks. You can go to this website and take a look at this. Let's see if we can get there. Basically, it takes you to the American Heart Association's website, and then you can just launch the web version of it. And give it a moment. And it's basically simple to fill out. Patients can fill it out themselves. They can choose gender. They type in their age, their race, what their HDL is, what their total cholesterol is, okay, whether they have diabetes or not, hypertension, their systolic blood pressure, and a smoker, and then it will give them a rating. So let's say male, let's say age 60, let's say African American, let's say total cholesterol was 240. Oh, didn't go in there, sorry. Well, we did something up there. Well, it says, no, lifetime is only calculated for 25, but it says 2079. So let's put in 58. That's a good number. Okay, total cholesterol. All right, HDL. Let's say the HDL was 40. And let's say the total cholesterol was 220. This patient does not have diabetes, does not have hypertension, and is not a smoker. And it should give me Well, it worked earlier when I put my stuff in. How about that? No. I need a systolic blood pressure. Let's say 130. This patient has a 10-year risk, 8.5% calculated risk with, and I don't really understand what this optimal risk is, but this patient has a 46% chance of, during their lifetime, having a coronary event type process. Okay, the risk factor is 8.5, and you'll see where that comes in as we go back and look at these issues. So what we're going to do is we're going to take that and put it together with all their other stuff, and then the physician will then determine what type of statin they want to do. And that's where number 6 is. Initiate the appropriate intensity of statin therapy. Now, these patients are going to be high dose, medium dose, and low dose statin therapies, okay? So high dose statin is to lower the LDL by 50% from the baseline. So these are primary prevention for patients with an LDL greater than 190, so they would need high dose statins. Adults age ranges 40 to 75 with an LDL of 70 to 189 and a 10-year risk for ASCVD disease of 7.5 or higher. So we can see our patient that we just had, because his 10-year risk is greater than 7.5, and if his LDL was somewhere in that range, he would need to be on high-dose statin regimen. Patients with diabetes, ages 40 to, it says 189. I don't think that's right. I think that's, I'll have to go back and look at that. With an LDL of 70 and a 10-year estimated risk of CV at 7.5. All of those folks would get high-dose statin levels. Moderate dosages basically are ranges recommended to lower the LDL by 30 to 49. Adults ages 40 to 75 with an LDL of 70 to 189 with a 10-year risk factor of 7.5 or higher. Or patients with diabetes ages 40 to 75 with an LDL of 70 to 189 and a 10-year risk of 7.5. So this patient, these patients would get that. Again, we as nurses are not going to be making these decisions, but you do need to kind of understand where it's coming from looking at these. And the low dose range of statins basically is to decrease the LDLs by less than 30%. And this is reserved for patients who cannot tolerate moderate doses of statins. Remember, there are patients who have problems taking the statins. It will cause fatigue, muscle weakness. Those type of pains can be caused with these patients. Again, we did use with ATP3, there were several types of medications used, but typically with the ATP4, statins are your drug of choice for this. The only people that will not be on statins are the ones who cannot tolerate them, those that have the severe myopathies or the elevation of the liver enzymes. But even with the elevation of liver enzymes, most of the other drugs are going to cause those same type problems as well. So, but these patients who maybe can't tolerate the statins may go to a different drug, and then again, that's going to be up to the physician to make those. Again, up to you to educate the patient on those medications. Now, when you look at the statin therapy, high intensity, if we're doing that high intensity, there are only 2 drugs that are recommended for high intensity. That's atorvastatin, 40 to 80 milligrams, a rosuvastatin, 20 milligrams for those, okay? But if you look at moderate, almost any of them can be used for the moderate. The low intensities, they do recommend the Zocor or the simvastatins, the pravastatins, the lovastatins, which are the early ones. The atorvastatin tends to have less side effects than the other categories of medications. What I want you to know about the statin drugs basically is when to give them, side effects that go along with them, what you need to educate the patient on with them, any contraindications to giving those medications, any medications that you could not give them with, or drugs that you could not give them, drugs or foods that you wouldn't give those with. That's what I want you to know about the statin therapies as you look at those medications. Seventh step in the clinical practice guideline is evidence is inadequate to support treatment to specific LDLC or non-HDLC goals. This goes back to the ATP3, where we treated to a specific number. We tried to lower that LDL down to less than 70 with patients who had cardiovascular disease or who had diabetes. Or we tried to lower that LDL down to less than 100 in patients who maybe only had just mild cardiovascular disease and no other risk factors. Same thing with the HDL. We tried to get the HDL up over 40 if at all possible. The ATP4 does not treat to a specific LDLC or HDLC goal. It treats that patient based on risk factors. And these patients, the eighth part, these patients have to be monitored regularly for adherence to lifestyle and statin therapy. Every time they come to the office, if you're going to work in a physician's office, you got to talk to them about: are you exercising? Are you following your diet? Are you taking your medications like you're supposed to be? Adherence is a big problem. Many times patients will take these statin drugs, start having the fatigue, start having the muscle aches, and all they'll do is stop the medication. They won't come back to their provider and let the provider know they stopped the medications. The biggest thing is to keep encouraging them about the lifestyle as well. Are you exercising? And helping them meet their goals as far as weight loss, hypertension, those type issues. Now, going to talk a little bit about ATP3, simply because you guys are kind of caught in the middle. I'm not sure whether because again the ATP4 has not been published, and these guidelines by the American Heart Association and American College of Cardiology have just been published in November, whether your NCLEX will have ATP4 or ATP3 on that. So you kind of have to have a little bit of understanding of both. I think if you'll understand lifestyle therapies and changes and looking at those and knowing about the different drugs, you will be okay. ATP3 was based on steps in therapeutic lifestyle changes. When these patients came in, depending on what their levels were, we started them on lifestyle therapies before we would start them on medications. And then we would see how well they did in lowering their LDL levels. Our goal was treating to an LDL level. Again, it depending on what type of problem the patient had, how many risk factors they had for cardiovascular disease, as to whether we treated them initially. Again, if they had diabetes and hypertension and had already had an MI, our goal was less than 70 on the LDL. If they had never had an MI and maybe had diabetes, we would get them down to less than 100. But the whole goal was treating to a number. But again, part of this is, adherence to some of these as we go along. Again, here are the numbers, and you still will need to know your numbers because you really want to see where your patient is many times, even though we're not treating to a number. But again, we want the total cholesterol to be less than 200. If it's above 200, then of course we're concerned with our patients. When we look at the LDL, optimal is less than 70 in patients who are high risk, or less than 100 who is moderate. Again, those are what we want to do. You saw back as we looked at some of the ATP4, the very high, the 190 range is what we look at in that high intensity type thing. So we're still using these numbers that were in the ATP3 in our ATP4 guidelines. Our HDL, basically if it's less than 40 it's low, if it's greater than 60 it's high. The good thing for you to know is with an LDL greater than 60, that's almost like striking off a risk factor. An HDL greater than 60 is basically a protective factor against cardiovascular disease. And the way to improve your HDL cholesterol is through exercise. Exercise will convert LDL cholesterol over into HDL cholesterol. The triglycerides tend to come more with your diabetes patients. We want to try to keep those triglycerides less than 150. You may see very high elevated triglycerides with metabolic syndrome, and you can also see it with pancreatitis. See these elevated serum triglycerides with the patients. So The different drugs that we use to treat hyperlipidemia, again, we've talked about with ATP4, our statin drugs, which are HMG-CoA reductase inhibitors, statins for short, are the ones that we're really going to be using for ATP4. Now, they can reduce the LDL from anywhere from 18 to 55%. They can raise the HDL from 5 to 15%, and they can lower the triglycerides from anywhere from 7 to 30%. The biggest problem with these side effects are the myopathies, the fatigue, and the increased liver enzymes. It's very bad on the liver. Absolute contraindications to giving the statins are active or chronic liver disease, relative causes of not giving these medications can include certain drugs, drugs such as cyclosporin, the macrolides, antibiotics, and various antifungals, and anything that has a cytochrome P450 inhibitor in it, which are like your fibrinates and your niacins, can increase the side effects and increase the problems that go along with these medications. In clinical trials, and that's why so much of this is back on the statins, in clinical trials they have been shown to reduce coronary events and deaths from coronary procedures. So statins are very, very important in our battle against coronary artery disease. Bile acid sequestrants are another ones. These are your drugs like cholestyramine, cholestyramine. These are drugs that basically work in the gastrointestinal tract, blocking the absorption of some of these medications. They can lower the LDLs up to 30% and raise the HDLs, have absolutely no effect on triglycerides. But because of how they work, they can cause gastrointestinal distresses, constipation, and decreased absorption of other drugs. So you have to be very careful in doing these with these patients. But again, not one you're going to be seeing as often. The nicotinic acids, I doubt you're going to see it all. The good part about the nicotinic acids is they work very well with the triglycerides. So if you have someone that has very high triglycerides, the nicotinic acids are going to be, this is like your niacin is the major one that we see with this. You can see it can lower the triglycerides up to 50%, and it has a great effect in raising the HDL. But most people have trouble tolerating it because it causes a severe flushing type process. When they take it, many times their whole body will turn red. They feel like they're burning all over. This typically will go away in about 30 minutes. A lot of times it can be prevented by having them take an aspirin an hour before taking this medication. But it also can cause hepatotoxicity. Absolute contraindications are chronic liver disease, severe gout. Relative contraindications are diabetes, hyperuricemia, and peptic ulcer disease on these patients. Fibrinic acids are another drug that can be used. Again, I don't think you're going to see these being used very much. These are basically almost like basically binding together with the cholesterol. Basically, this is gemfibrozol, which is given as 600 milligrams twice a day type process. You can see they can only lower the LDL at the maximum 20%. But it will also lower the triglycerides some and raise the HDL some. It can cause dyspepsia, it can cause gallstones, it can cause myopathy, and there has been some unexplained non-coronary heart disease deaths in World Health Organization studies. Absolute contraindications, severe renal disease, or severe hepatic disease. Again, not something you're going to be seeing used as much. Now, other risk factors, we kind of beat hyperlipidemia to death. So some of the other risk factors that we look at, tobacco use. Again, tobacco is a huge problem in the U.S. today. It is a major risk factor when we look at cardiovascular disease. It's estimated that 2.34% of men and 18.5% of women smoke. and approximately another 5 million people in the U.S. dip or chew. Also know that secondhand smoke can also lead to coronary artery disease as we look at these problems. It's the nicotine that is the big problem that we see with this. The nicotine enhances that process of atherosclerosis. When you take in nicotine, it causes the release of catecholamines, and those catecholamines increase the heart rate, which if you have ischemia is going to make it much worse. It also causes vasoconstriction peripherally. So if you cause vasoconstriction peripherally, you're increasing the afterload that the heart has to work against. So if you're increasing the afterload, you're increasing the heart pressure, and you're going to increase the oxygen demand on the heart because you're increasing the workload on the heart. Nicotine can also cause endothelial dysfunction and can increase vessel wall thickness. The nicotine also causes an increased risk of clot formation and vessel occlusion, so beware. Also, the other thing to look at is when you're smoking and you're taking in the smoke from those, you're taking in carbon dioxide, and that carbon dioxide is replacing the CO2 in the system. So now you have less oxygen in the blood to get to the myocardium. So it is a big problem when we look at those type issues. Now, exercise when we look at it is a big problem. It's estimated that basically 97 million adults in the U.S. are overweight. And of course, we know that obesity leads to hypertension and diabetes, which are both significant risk factors for coronary artery disease for that. Your book says that physical inactivity may be the most important risk factor to the general population for coronary artery disease. We see that physical activity is more common among women than men, more common among African Americans and Hispanics than the Euro-Americans, and typically we see physical inactivity more with the older generations than the younger populations as we look at it. The big thing when we look at and we start talking to our patients is you got to start. You got to get moving somehow, some way. Walking is probably the best way for most of our population to get started when we look at exercise. The recommendations from the American Heart Association for overall cardiovascular fitness is at least 30 minutes of moderate to intense aerobic activity at least 5 days a week for a total of 150 minutes a week, or at least 25 minutes of vigorous aerobic activity for 3 days per week for a total of 75 minutes, and or a combination of moderate and vigorous intensity aerobic exercise and moderate high intensity muscle strengthening at least 2 days a week. So basically exercise. Most of our population are not going to be able to do this right away. If we can get them on a walking program and we can get them started and build them up, if we can get them to walking 5 minutes 3 times a day, getting up and just going, moving away from the desk, and then gradually building. That's what we really want to do with these patients. One thing with a lot of these patients who have already history of cardiovascular disease, you really don't want them to go into that moderate to intense type aerobic activity, because that moderate to activity can increase the risk of that plaque rupturing in the coronary arteries, and that we really don't want to happen, because then we are putting them into an issue with a coronary artery or with a coronary syndrome. Again, hypertension, we talked about, that is a big problem in cardiovascular disease. Hypertension is part of cardiovascular disease when we look at it. Estimated 50 million Americans have hypertension. How many more have hypertension and don't know it? It's really hard to measure. New standards coming out on blood pressure control. We're still trying to keep the blood pressure less than 120/80. You're going to be hearing some controversy over sodium intake and salt intake. Some are saying that we're restricting too much. Others saying that we need to increase the salt intake because it's necessary for the normal body processes. So that debate goes on. You can find literature that supports either goal with those type processes. Again, with hypertension, weight loss and exercise are the big things in controlling the hypertension. Stopping smoking will also control the hypertension. Diabetes is another risk factor as we look at coronary artery disease. Estimated 15 million Americans with diabetes. The goal is to get that hemoglobin A1C less than 7 and keep it that way. Again, diet, exercise, weight loss, all of those are important in keeping the diabetes under control. One thing to understand that patients who have diabetes may not experience the typical type chest pain as a normal person would. So these patients may not have that substernal pressure chest pain that's radiating to the shoulder. They may just feel weak, fatigued, those type issues. They may not have that radiation because of some of the neuropathies that are going on. While I'm here, let me also say that women may not experience that substernal pressure feeling chest pain that goes along that we think about when we think about an MI that's going on, and we'll talk about that a little bit more. Other risk factors, basically stress. Stress is going to increase our blood pressure, increase our heart rate, increase the release of cortisols. So all of those can be bad as we look at it. Alcohol is getting more and more a bad rap. As we look at it, there's more studies coming out that even minimal amounts of alcohol can be dangerous not only to the heart but to the brain as well. If you drink alcohol, I recommend moderation. If you don't drink alcohol, don't worry about trying to start a glass of red wine at night to help with cardiovascular disease. You can get the same thing from the nice red grape juice. Purple grape juice is the antioxidants with that. But if you're taking alcohol in excess of 3 ounces per day, that can actually increase your risk of cardiovascular disease. Now, the non-modifiable risk factors are age. Most coronary events and deaths related to these occur after the age of 65. So as we get older, our risks go up. As we think about as we get older, we tend to get blood pressure problems. We become less active. Our diet is probably not as good. And we talked about with women, basically as women go through menopause, their risk for coronary artery disease goes up. Gender. Men have a greater risk for coronary artery disease than women until women go through menopause. But once women go through menopause, their risk factors are equal. Women over 50 are more likely to die within the first year after an MI. So women who have MIs basically have a greater chance of dying from that heart attack. Many times women do not do as well with bypass grafts as do men as well, especially if they have diabetes. Family history. We can't do anything about family history, but if you have a first-degree relative with coronary artery disease, or you have a significant family member, a first-degree member, especially a male who's had an MI before the age of 50, women before the age of 60, those are significant type things you need to note in your history. Now, the ethnic background, again, something we can't do anything about, but African Americans have the highest rate of coronary artery disease and the highest mortality rate and the highest out-of-hospital coronary death rate in the U.S. So those are some of the things we need to be aware of. That's a good place to focus our attention as far as educating the population about coronary artery disease. That pretty much covers the risk factors. Our next session will actually start beginning to look at coronary artery disease, looking at some of the different issues that go along with it. Have a good evening.